Good afternoon. Welcome to today's Wisconsin Health News virtual briefing on the state of rural health in Wisconsin. My name is Tim Stum. I'm the editor of Wisconsin Health News. Thanks to all of you for tuning in today. We have a really great panel with us today to talk about this important topic. I am thrilled to introduce John Ike, Director of the Wisconsin Office of Rural Health, Reba Rice, Chief Community Officer for North Lakes Community Clinic, Bob Van Meeteren, CEO of Reedsburg Area Medical Center, Dr. Lisa Grill Dodson, the founding campus dean emeritus for the Medical College of Wisconsin, Central Wisconsin, and Dr. Amy Kine, associate dean for social health sciences and programs at the University of Wisconsin School of Medicine and Public Health. Thank you all for sharing some of your valuable time with us today. Before we get started, I want to make sure we thank our very generous sponsors of the Wisconsin Health News virtual series. Healthcare leaders from across the state sign up to watch these virtual events, and they would not be possible without the generous support of our sponsors. So a huge thank you to Aurora Healthcare, AARP Wisconsin, Anthem Blue Cross and Blue Shield of Wisconsin, Delta Dental of Wisconsin, Amplify Health, and Quartz. Wisconsin Health News is an online, nonpartisan news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial, which you can do on our website at wisconsinhealthnews.com. And an extra thanks today to Aurora Healthcare, today's featured sponsor. We're really grateful for all of their very generous and continued support. Here to say a few words is Jeff Bard, Executive Vice President for Aurora's North Wisconsin region.
Great. Thank you, Tim. Thank you, everybody who's made some time for such an important issue facing the nation as well as ourselves here in the state of Wisconsin. Further, thank you for the various health systems that are trying to solve mightily, as is Aurora Healthcare, to continue to provide care in our rural communities. So as Tim shared, Jeff Bard, I serve as the hospital president in both Oshkosh and Fond du Lac. Also have a regional role across our northern footprint. We at Aurora are 18 hospitals strong here in the state, 70 pharmacies, 300 sites of care, and are clearly dedicated to our commitment to those that we serve. A couple of examples that I thought might just be a good teaser as we get into this space with our fine panelists here is that up in Marinette, Wisconsin, just a stone's throw from the Upper Peninsula of Michigan, we have an ambulance service, and that ambulance service provides EMS support for 470 square miles of residents that are dependent upon that transportation when they have an emergent situation. We're also proud to invest in rural education, as are others across the state. We have a warm program in partnership with UW-Madison that specifically prepares physicians to commit and practice in rural practices, and that is based out of our Aurora Lakeland facility. And then the other example that many of us are solving for, Aurora certainly is a leader in, is our virtual technology, recognizing the importance of providing care in that capacity, or as there's just less talent coming our way and calling Wisconsin home. So proud to be a part of this conversation, as well as a sponsorship, Tim, to this vitally important conversation. So look forward to the dialogue. Thanks.
Thank you, Jeff. Some great words to get us started on. And thanks again to Aurora Healthcare for all of the generous and continued support. And thanks again to our panelists for sharing some of their time with us today. Rural healthcare in Wisconsin is at a crossroads. Medicaid revenue is expected to plummet in the coming years. OB-GYN deserts are widening and provider shortages persist. So what does this all mean for the future of care in Wisconsin's less populated regions when more hospitals band together to stay financially solvent? How will the state set up a new federal fund for rural health? How are providers adapting technology? And what impact could it have on workforce challenges? We have assembled a virtual panel of experts today to discuss these pressing questions and more. And John, let's start with you. Thank you again for doing this. What's the state of rural healthcare in Wisconsin right now?
Well, I think you hit the main points there. I mean, workforce is clearly something we can all talk about from different directions. And I think too, it's not just open positions that are trying to be filled. You have to look at what does that mean for scheduling for patients. You know, you're scheduling further and further out. What does it mean for the burnout for the existing employees? You know, the staff that is now working more than they normally would. Times are harder. Patients are coming in perhaps grumpy because of how long it's been. So there are a lot of impacts there that ripple out through the system. I think obviously the Medicaid hit is going to be hard to take, especially when you look at rural patients. Rural patients tend to have, or rural citizens in general tend to have fewer jobs that offer healthcare insurance. So we're looking at maybe multiple part-time jobs. Again, trouble scheduling. We're looking at not private insurance, public insurance, which again just took a hit. So these things are hard to take in rural areas. Our specialty care, clearly, it's going to influence that when it's already thinner than we'd like it. I think EMS even is something that we're not talking about as much with Medicaid, but is something that is really strained across the state. So there's a lot of strength, there's a lot of talent, there's a lot of great outcomes that are happening, but at the same time, the pressures are mounting on us.
Thank you, John. Dr. Kine, what would you add to that? What are the most pressing issues facing rural healthcare in Wisconsin right now?
Well, I think John did a wonderful, wonderful job of providing a broad overview. I have to tell you, I grew up in rural northern Wisconsin in a little town called Niagara in Marinette County that Jeff was just talking about, with the EMS services that reach hundreds and hundreds of miles. And I go back regularly and see infrastructure that continues to crumble, people who are continuing to be challenged by health concerns that are perhaps increasing for a whole host of issues, partly about access, partly about workforce and infrastructure, but partly about the broader community context that are moving forward and some of the other pressures that are on health and that impact health in our rural communities. So I do think that this is a time for innovation. It's a time for coming together and building new partnerships that traditionally may not have otherwise occurred. And I think we have to reinvent the status quo and think about new ways to incorporate technology, incorporate digital infrastructure, and approach workforce in a completely new way in order to be sure that our rural communities and the providers who serve them, the hospitals and systems that serve them, are as strong as possible going forward.
Thank you, Dr. Kine. Bob, what would you say are the biggest issues facing rural hospitals right now?
Well, it's always easy to talk about workforce. It's always easy to talk about access. Those are some big ones, but the one topic that hasn't been talked about is reimbursement. Out here in rural, a greater percentage of the patients that we care for are going to be government patients, whether it be Medicare, Medicaid. So Medicare Advantage plans have always been a challenge for those of us in rural. And then just, the ability to negotiate with some of the different insurance companies. When you're a smaller standalone organization, you don't carry a whole lot of leverage when it comes to the negotiating table. So we all want to reinvest in the infrastructure. We all want to reinvest in more technology and AI. We want to be competitive with our wages and benefits and all those types of things. But that is reliant upon a good, solid reimbursement for the services that we provide. So I think reimbursement always has to be a topic of discussion anytime we're talking about challenges in rural healthcare.
Thank you, Bob. Reba, what would you say are the most important issues facing community health centers in rural parts of the state?
Yeah, well, my colleagues are hitting so many of the highlights and making my brain light up. To Bob's point, I think really around reimbursement, the managed care organization landscape in Wisconsin is intense and a little crazy, and really could be, we should look at that for sure. That's a big impact, especially as we're looking at reduced amount of dollars going into public insurance. I also think that as we've talked about, the workforce pieces are real. I think that there's a very strong cultural impact to that as well, that as our populations in rural areas age, for patients, they're needing more and more care, and our workforce is younger. Obviously, just because those are the people who are working, and they are more focused on work-life balance than previous generations, which is great. I'm all for work-life balance. But that is a mismatch there, where we've got people who need more care. We've got a shrinking workforce and a workforce that wants to work less than healthcare often makes possible. Also, we're a federally qualified health center, so we're doing comprehensive integrated primary care. systems that are not able to continue to do community services like behavioral health units, et cetera. And so those systems and services, not systems, but those services declining means that more and more pressure goes on primary care providers and outpatient providers. And when the acuity is just too great for us, that really does contribute to burnout and lack of appropriate access for patients to the services that they need. If they have really complex needs that can only be met in an inpatient facility, but their only opportunities are outpatient, and even sometimes their only opportunities are family medicine instead of psychiatry. That is a big burden, and we can't always support we don't always have the population to support those kinds of subspecialties in the smaller areas. And while telehealth is absolutely the future of healthcare, especially in rural areas, it's a rough time right now. We're just adjusting to that, and there are some things that are just not a really good fit for telehealth, like inpatient behavioral health, right? That's just not something you can do from your laptop at home. So
thank you, Reba. Dr. Dodson, what did they miss? It's a long list. It's a comprehensive list, but what else? What are some of the other pressing issues facing rural healthcare in Wisconsin right now? Dr. Dodson, I think you're still muted.
Sorry.
No problem.
All of those challenges exist: recruitment, retention, burnout, facilities, payment, the whole gamut. I'm going to throw a little positivity into it though, because there's really great data to show that if you train students and residents closer to where we want them to practice, they will go do it. And students and residents who experience a broad scope of practice often are happier, have more sustainable careers, and less burnout. And so I think that this is an opportunity for some partnerships to demonstrate the joy of rural practice as well as the difficulties. I mean, we want to give students a realistic view of what their life will be like, but having personal experience as a rural doc and working with our students who are experiencing rural communities, there's a lot of joy in what we get to do and the connections that we get to make to our communities. And so I think it's a real time for partnerships to help our students and residents make sure that they get to experience that at a time when they're still making decisions about their careers.
Excellent, thank you. John, as your office has detailed in recent reports, as we have reported in Wisconsin Health News and as other publications have reported on, specifically birthing services in rural Wisconsin, like other rural parts of the country, is declining. What do you attribute that to? What were the main factors driving that, and what are the implications of that?
Workforce, as we've discussed, and cost. These are incredibly well-trained people, as in every specialty, but they are on call a lot. That has a lot of impacts to families. You have providers needing to share those burdens across larger distances, so that can be challenging. We're also seeing sort of a shift away, so our office operates a physician recruiting service, and we're seeing fewer services or employers that are interested in maybe a family practice doc who also does OB. But at the same time, you've got a lot of new docs coming out of the system, out of training, who want that. And so I think it's hard to find that specific need, like we have this amount of birthing services or OB services, we don't have that. So trying to find just the right jigsaw puzzle piece of a provider, that just makes recruitment harder. It makes retention more difficult. If you've hired somebody 5 years ago who was very excited about a certain aspect and then that changes. So clearly workforce, I think back to Bob's point, the reimbursement, the cost of the services compared to the amount of reimbursement for it is at a mismatch. And then finally, I would say, and something really that we could look at as far as general issues for rural, increasingly we have more system-owned local hospitals. And so when decisions are made remotely, they're made from far away, we can really focus on the accounting side of it. When you have local care, local decisions for that local care, you have a bit more leeway to say, well, this is making us less money. It's a bit of a struggle, but it's what the community needs. We've seen that in SNFs or nursing homes as well. When an independent hospital can make that decision, a system-owned hospital might make a different decision. So I think those kind of economic pressures are felt acutely at a remote distance, and the local providers are less able to flex with that. I think there's a lot of interest in this. That's good to see. There's a rural training track, here in Wisconsin for OB. There's a lot of good ideas. I think maybe it will put a little pressure on some entrenched patterns as far as can we get a little more team-based care? Do we need an OB-GYN surgically trained for every prenatal and postnatal visit? Perhaps not. And so that's a tiny silver lining, but I really worry about what this means. Also, the ripple effects. What does this mean if you're not offering birthing services at a hospital? What does that impact to your surgery, your anesthesiology, and your pediatrics? And suddenly they have fewer patients as well. So there's a lot of pressures here, and I don't yet hear solid financial solutions advancing, at least.
Can I
Bob,
add
can
to
you talk
that,
about
Tim,
your
just
experience
quickly?
at Reedsburg? I mean, what are some of the specialties that you struggle to provide at a smaller rural hospital, and some of the workforce challenges that you face at a hospital like Reedsburg?
Well, I think if to stay on the OB model, we about a year ago kicked off a transformation of our OB services, and one of our OB-GYNs helped create a group through the Rural Wisconsin Health Co-op and a number of hospitals. And what we are doing now as far as offering OB services, we have a combination of our family doctors that choose to provide OB services. We have 2 OB-GYNs that provide OB services. We have 3 nurse midwives that provide OB services. I'm actually missing a luncheon with one of those new nurse midwives that's joining us to be with you fine folks today. And then we also have general surgeons. So from our model, really the biggest issue that we were looking at was burnout. And to address the burnout issue, we wanted to make sure that we had enough providers that we could share that call burden, that we could still provide the level of care that our patients have come to expect. But again, not everything falls onto the shoulders of 2 OB-GYNs to do all of your C-sections. John brought up a point earlier about recruiting family practice physicians, and I'll tell you, last summer we brought 3 new family practice physicians to join our organization. Not one of those young family practitioners had any desire to integrate obstetrics as part of their family medicine practice, which was fine. The last 3 family practitioners that I've interviewed, one is already in a OB fellowship program. The other 2, one has been accepted into an OB fellowship program as part of her family as she finishes up her family medicine residency. And one family practitioner is offering OB services as part of his family practice that he has. So I can't say that, at one time I was thinking, I don't know if I'm going to find a family doctor that's going to offer OB as part of their practice anymore. And then I get a number of young men and women who are saying, yes, it is something that I want to practice as part of ours. So we also are moving to a provider of the day model. So, there could have been a time where I might have 2 nurse midwives that are up all night laboring with a patient. And then tomorrow I have 2 nurse midwives that are very tired, maybe who have to cancel some of their patients in the clinic the following day. So we are implementing a provider of the day model, and our patients, we haven't seen any pushback from the patients. It's been accepted really well in the community. But again, that provider of the day model makes sure that only one person is up all night laboring with those moms and so on. And then tomorrow they can go rest. They don't have any clinic obligations. And it's been a model that as we're recruiting more providers in, we're having a lot of success bringing people into that model. It is different than what we've done historically here at Reedsburg, but it definitely, we see as far as moving forward, we're going to continue providing excellent care, but we have a model that we can recruit into, and we're reducing that burnout.
Excellent. Reba, there's been a lot of headlines about the GOP's Big Beautiful Bill and the impact that this could have in terms of declining Medicaid revenue on providers in rural parts of the state. Can you just talk a little bit about the impact that you expect that to have at North Lakes and other rural community centers, community health centers in Wisconsin?
Sure. Yeah. We know that it's going to hit our rural communities harder than our urban counterparts. And so that's, scary because we're already always struggling to stay on the silver lining side of the cloud. But with what we think, the way that we're preparing for this is that there are a huge number of people who will remain eligible, and so we just have to work a little bit harder. Community health centers are kind of set up for this because we already do support people getting enrolled and staying enrolled. And so at the state level, what we're talking about, and as individual health centers, we're talking about just making sure that we're on top of all the enrollment requirements so that the 70% of working adults who are currently enrolled in Medicaid just don't fall off. Because I think the added administrative burdens are really going to be the biggest culprit for what's going to make people fall off of Medicaid. And so we just see it as our job. And I'm sure my colleagues here are going to be working on that to the extent that they're involved in frontline care to make sure that people stay on Medicaid. So I think that's my our main concern right now is just how do we backfill our own positions so that we're prepared to keep people on MA who are eligible.
Bob, how are you preparing for these changes at Reedsburg? Wisconsin lawmakers helped thwart a decent amount of the impact from a revenue hit by passing a new hospital assessment this summer. What is this going to mean from a kind of a revenue standpoint for Reedsburg? How will this still impact Reedsburg? And how are you preparing for these kind of looming Medicaid changes?
Well, the directed payment program certainly will be a positive for Reedsburg, but it is a 10-year program and it's going to decrease, by 10%, I believe, each of those 10 years. So, we expect to see a bolus of money on the front side of that. And what do we do with that? Obviously, as a small rural facility, there's always room to improve the infrastructure, update. We're very fortunate. We just opened up a new clinic earlier this year in January, so it's coming up on about a year. But there's plenty of things that we can do with those dollars. And again, as we've talked about before, workforce, making sure that our workforce is well taken care of. Do we have any debts that we can pay down? So yeah, we do expect that there's going to be some money coming from that. Our federal government has to open back up so CMS can actually approve this program. That's a whole separate discussion for a different day. But as far as what impacts do we expect to see from Medicaid, it's really hard to tell exactly, what percentages we are going to see. We do take care of uninsured patients every single day. It's part of who we are as an organization. It's the mission of what we do. So we'll just continue to look for ways to offset any of those losses. We're always looking to, open up new areas of service, new service lines, new providers that we haven't in the organization. So right now, it's unknown a little bit to me as far as what that impact will be, but that's rural healthcare. I mean, you don't go into rural healthcare because this is an easy job and you know what tomorrow's going to bring. So I guess to me, it's just part of the job and maybe part of the weird attraction that we all have to rural healthcare.
So they kind of shift gears a little bit. Rural healthcare in Wisconsin is certainly facing some significant challenges, from access to workforce to reimbursement. But there's also some big innovative efforts underway to address these challenges. John, the Big Beautiful Bill also includes a $50 billion fund aimed to offset revenue losses in rural parts of the country. Half of that will be divided among the states. The other half will be distributed through grants. The Department of Health Services is applying for up to $1 billion on behalf of the state. I know that the office has been involved in some kind of preliminary discussions with the federal government and the state government. Can you just kind of give us a kind of a brief, broad kind of overlay of the impact that this fund could have and kind of where things are with that right now?
Absolutely. And you know, I think the timing of it, around the same time they were talking about the Medicaid cuts, it was easy to see this as, in a sense, sort of an outreach to rural, saying, "We're sorry about these cuts. We know it's going to hit you hard. Here's a bunch of money." But interestingly, in the notice of award, they were very clear about not wanting to supplant anything that had been cut or other payments. And they stressed it over and over in the notice of award. We want to see projects described. We want to see outcomes listed. It was so well written, frankly, I wondered if it was written by AI, because it's just so much better than normal federal options. But anyway, so yeah, heavy reliance on what are you going to change. All that being said, they gave states months to come up with something that is spending a lot of money very quickly. Can be extremely challenging. We've seen this before in preparedness funds and even COVID funding, where it was a lot of money, but at the same time, the timelines are short and it doesn't give people a chance to really plan well. A lot of ideas were put forward at the state. I think the state is nonetheless pretty constrained by those federal guidelines. Also, the feds have done something unusual, saying that they are willing to pull the money back if we don't achieve those outcomes. So again, I think we're going to see a lot of reliance on what are we promising will change by spending this money. We haven't heard yet how the state is planning to move forward. We haven't seen real details, but at the same time, we've heard it's pretty clear in the federal award what they want to spend it on: technology, workforce, etc. They want to see radical innovation, which I'm not sure. I don't think it's that much money. It's a lot of money, but radical healthcare transformation, that we've been down this road before. You can't buy it for that amount of money, and it does take time, and it takes a lot of cohesion, which we don't really have politically these days. So I love seeing Wisconsin come together, rural Wisconsin come together with ideas and innovations and solutions. It's DHS's job to figure out what they're going to fund. I imagine we'll see it change. But I don't know that we'll get that sort of one-to-one fix for what the big, beautiful bill is also pulling back from us.
Dr. Kind, it's my understanding that UW, is among the numerous entities that submitted proposals to DHS on what they'd like to see in terms of how that fund is used. Can you just talk a little bit kind of broadly about that proposal that UW sent over?
Absolutely, Tim. And certainly echoing a lot of what John said, the emphasis on the RHT funds is about innovation. And one of the things that UW can bring is a network and opportunities for partnership around innovation. So we have been involved, for instance, in the Tech Hub, one of the few states that competed successfully for a Tech Hub infrastructure that allows us to think about data, fundamental data infrastructure across our rural communities in completely different ways. These are the types of fundamental investments that can really lead to a transformative change, but just as John said, these do cost quite a bit of money. So one of the things that UW put forward is this idea of investment in data infrastructure, fundamental data infrastructure that will benefit pharmacies, they will benefit rural providers across the board, and ultimately lead to better, more aligned care for patients. We also put forward ideas around rural workforce. And certainly I agree with what Dr. Dodson said. You train individuals in rural areas, they're more apt to stay in those rural areas. So thinking about opportunities to build capacity for post-baccalaureate training in nursing and pharmacy and medicine and in other areas that are important to our healthcare infrastructure in ways that require substantial upfront investment, but then can lead to multiple benefits across the board. And then finally, a future-facing investment was proposed. Just as John said, it does take time. It takes time for any large infrastructure to change its direction. So thinking about investing in innovative models that bring our rural providers, rural systems together with individuals who are developing new technologies and thinking about new robotics and telehealth approaches, and ultimately leading to partnerships with industry that could be novel, helping us forward and allowing Wisconsin to become the rural learning system laboratory to help us know how to reinvent rural care across the board.
Thank you. Reba, what would community health centers like to see from this fund?
Yeah, it's really exciting to hear these because our proposal that the Wisconsin Primary Healthcare Association submitted to DHS is really similar. One of the things that we're really focused on is wanting to make sure that we're distributing those dollars across all levels of care, right? Not just thinking about hospitals or thinking about primary care or thinking about systems, but thinking about how important all of us are in the delivery of healthcare in Wisconsin. But the three concepts that WIPCA asked DHS to consider are digital access and technology, workforce supports, and that coordinated model of care that Dr. Kind was just talking about. That's not just about making sure that this provider talks to this provider, but using technology and all of the advancements that we can to make sure that we're not just coordinating within our system, but across our systems.
Thank you. Bob, what do hospitals want to see out of this fund?
Well, I guess, what we're looking for is the things that have already been said. Technology. How can we better use technology in the organization? There's been a lot of talk about ambient AI technology in the clinical setting, whether it's my nurses in the inpatient room or a physician provider in the clinic setting. I believe some of that technology certainly provides a lot of opportunity to improve documentation, but also to reduce workload, so people can go home at the end of the day feeling accomplished and feeling that they did a really good job. So I think there's some great opportunities there. Recruitment, one of the things we talked about early on. I'd like to be able to use some of these dollars for some additional recruitment, retention, those types of things. And then it sounds funny for me to say, but some of our more rural areas that we serve, how can I bring services out to those areas, the smaller communities, those communities of 800 outside of Reedsburg that we take care of? Can I bring pharmaceutical services out there? Can I bring clinic services out to there so people don't have to come into Reedsburg? So I think there's a lot of opportunity. The one thing that I do want to caution about is when there's, again, a large chunk of money for a short period of time, a relatively short period of time, what technologies, what can we implement that's going to be sustainable? Because again, as rural organizations, we have limited funding that we're always working with. So the caution, the fear that I have is that we implement these new programs, but is it going to be sustainable when the money goes away?
Yep, thank you. Dr. Dodson, what would you like to see out of this fund? Has MCW put together a proposal as well?
Sure. Yeah, the MCW's proposals were largely related to workforce, so specifically restoring rural residencies. We had sponsored a rural residency in Eau Claire that reached out to multiple communities around there that was closed as a result of the HSHS hospital closures, because that was the supporting hospital. So restoring experiences for family medicine residents and others in OB and other places for rural rotations in the rural parts of the state. Also, something really important is our WISCOPE program at MCW, which is an outreach to any provider in the state can get psychiatric consultation in real time. So expanding that program and extending it across the state. We've had a program for children for years, and we have a pilot program for adults that will really extend the capacity of family doctors, practitioners, PAs, others who provide the care when they've got a complex situation and can't wait, as Rhea was saying, for an inpatient bed, but can reach out and get immediate real-time help from psychiatrists at MCW. So that program would be really important and part of our mental health and behavioral health expansion.
Excellent, thank you. Dr. Kind, you wear a number of hats at UW. One of your more recent ones is the head of a new initiative, a somewhat new initiative called the Orion Initiative. Can you just tell us a little bit about what this is? Why was this formed, and what are the goals, and what impact could this have on rural health in Wisconsin?
Absolutely. Thanks, Tim. The Orion Initiative came about by a very generous philanthropic gift in order to allow us to invest in the transformative power of partnership between frontline rural providers and academic medical community in order to transform rural health. Our donor is interested in ultimately changing the face of rural healthcare and being bold and innovative with our frontline rural providers in order to understand exactly what their needs are right now in October 25 and forward, but also to ensure that their voices are elevated throughout the design and intervention process. So one of the new initiatives that it's moving forward with Orion are programs that bring together subspecialty physicians with frontline rural providers to increase those rural providers' ability to engage in certain subspecialty care, deliver certain subspecialty care. Those are very exciting. We have partnerships that are growing across the state. But today I'm very pleased to announce a brand new initiative called Recruit PCP. This was designed in partnership with Gunderson Mound View Hospital, with Frank Perez Guerrera, who's the CEO there, Lori Wittig, who's the Director of Inpatient Operations, Aaron Bonnet, Executive Director of Business Operations, Nicole Bonk, our Chief Medical Officer for Recruitment, and Jennifer Stiegel, our Administrative Director. And what they are doing, and they worked with Frank and his team at Gunderson Mound View because they had not had a physician, permanent physician on staff for over 7 years. And the current infrastructure that was available for recruitment was not working for them, and we needed to invent something new. So this program went forward, and what it does is that the Orion Initiative, which is fundamentally a grant-making initiative, we provide grants to rural hospitals to do these innovative programs. The Orion Initiative supports a physician's time for 20% of the newly hired physician's time, allowing them to engage in community activities to benefit the health of their community, to teach students and residents, and to participate in research if they so wish. We know that these activities increase physician job satisfaction and professional growth, but they're often underfunded, as we all know. And yet in our academic context, it's very common for us to protect physician time as a tool of recruitment, and we want to provide this to our rural partners as well. So with this funding, I'm pleased to announce that Frank and his team successfully recruited a physician for the first time in 7 years. This person is seeing patients now in the Adams Friendship area. And given this success, as of today, we are spreading this program statewide. So hospitals and systems who are eligible are able to apply for these funds. Our team just sent out emails today to the first wave of hospitals that we're interested in reaching out to, but more will be coming. These individuals, these hospitals, we are prioritizing critical access hospitals in health professional shortage areas, and particularly in areas of great concentrated poverty, areas in which the communities themselves are in great need. So happy to share more, but we're very excited about this. We see this as an incredibly innovative step forward as a way that the School of Medicine and Public Health through the Orion Initiative can partner with our colleagues in rural areas and ultimately form stronger networks. With these recruitment incentives, we also work with retention activities in which we're trying to decrease the isolation of frontline provider experience and add the humanity back to healthcare. So a lot of those human pieces are not necessarily reimbursable. There's no RVU for connectivity in that way. But by ensuring that not only are we recruiting these physicians, but providing them with a ready network of academic colleagues and also their other rural colleagues to decrease isolation is one of the ways in which we're hoping that retention will happen as well. All of these physicians will have access to our STARS programs, and we do anticipate, given the funding that we have available, that additional innovative projects will roll out. All of these will be designed in partnership with frontline rural providers.
Excellent. Thank you, Dr. Kine.
Yep.
This is great. This sounds like a really great innovative program. I guess can you talk a little bit about how this is funded? I mean, how you're expanding this statewide, but is it possible to replicate, programs like this in other parts of the state and through other organizations? Like, what would it take? Would it take do we need just more donations, or how are we going to expand stuff like this to other parts of the state and other providers?
Well, I think that's a great question, Tim. And I fundamentally am a physician, but I'm also a researcher. So one of the things that we are doing is taking a very strong research lens to these new programs and ensuring that they work not just from a academic lens, but also from a rural lens, that our rural colleagues and our rural systems are benefiting from these programs. So we will be evaluating them very, very heavily. And with that evaluation data, that allows us to make this argument for spread. Because with some of these innovative rural concepts, we hope that not only will additional donations come in to be able to allow this to continue forward, but that then these become innovative new models that have been co-designed by our rural colleagues in partnership with the University of Wisconsin in order to change the face of rural healthcare. And by providing these funds in a way to build time to do so, to support those rural clinicians fully while they engage in these programs, we want to ensure that we are not decreasing the total revenue of a particular hospital or healthcare system, for instance, but supporting them as they engage in this important activity. I do think spread is possible. We are only 18 months into this program. You can imagine with there's a lot of infrastructure build that's required in order to have financial programs of this sort. We are learning as we go, but thus far we are very, very heartened by the response of our rural communities and rural partners because they are really the ones that are championing this program just as much as the University of Wisconsin.
Thank you. Dr. Dodson, we spoke a little bit before the program about how you were one of our first in-person panelists at Wisconsin Health News, just as we were getting started, just as the Medical College of Wisconsin's Central Wisconsin campus was getting off the ground. I graduated, I think, six classes since then. Can you just talk a little bit about the impact that this rural campus, along with your Northeastern Wisconsin campus, have had on addressing some of the workforce challenges in Wisconsin? What have been some of the highlights, and what have been maybe some of the challenges that still remain, from adding these campuses to rural parts of the state?
Yeah, thank you. It's been a really successful effort with a lot of partnership. As Dr. Kind noted, partnerships are kind of the way that you make this work. So we have had 7 classes graduate, and we have a total of about 250 students admitted to our campus. We only admit 24 students a year. And 80% of our students that are eligible to, more than 80% that are eligible to have returned, have gone off, finished their residency and fellowship training, have returned to Wisconsin, almost all of them to small towns. Many of them we have one practicing in Medford and Merrill, and some really small towns that have been very hard to recruit. Many of them are interested in obstetrics or full spectrum practice. 35% of our students are going into family medicine, which may not sound terribly impressive until you find out that less than 10% of students nationally go into family medicine. So we're well over 3 times the national average. We are getting somewhere around 62% of our students finish in 3 years rather than 4. So we're addressing their debt as part of their accelerated curriculum, and really demonstrating that we can train students very, very well in very small communities, demonstrate the value of practice there, and get them to come back. And so obviously we've only been around for, as I said, 7 graduating classes, but we are certainly, I think, proving we can do a pretty major impact on smaller communities, and that students will go and do what we ask them to do in a variety of very needed specialties. So we're really excited for what the future brings in terms of demonstrating that place-based education can happen in small communities.
Great, thank you. John, how is telehealth and virtual care being used to bridge some of these access and workforce gaps in rural communities? And what are some of the limitations of some of these solutions for rural parts of the state?
Telehealth has been around for a while, and the technology is pretty proven. I think studies have shown that patients do like, or they are willing to see a provider in a more convenient way more often than seeing someone in person, not as often. So I think all of that exists. has been proven. It's shown to work. I think I find it is often an urban answer to a rural problem. In other words, well, if you people out there can't get enough providers, why don't we just put them on the phone? And sure, I think there's so many ways that this works really well. I think like for the Orion Initiative, training people, sort of the Project Echo model, I think that's excellent. Providing support, specialty support for providers in the field who may not have as much training, that works really well. Patients, convenience for patients and scheduling, great. I think there's a stumbling block that we often don't talk about, and that's referral networks. What do you do when, like, where are those providers coming from and where are they providing their care? And is it in the same referral network? And if it's not, that can go against sort of the CFO's wishes. And so I think those things are challenges we don't really talk about. I think it has been shown to work. We have the technology, people are fine with it. The question is, can we make it work in our systems? And so I think there's a lot of potential. Certainly, I think as Reba said earlier, there are things where it doesn't work as well, and people want to talk to a person. They maybe the provider needs to put their hands on them, or they need to do a test, a lab. You can't really do labs over telehealth, and that's a big part of care these days. You have to be able to rule things out with labs. So yes, let's keep talking about it. I find it interesting that we have proven over COVID, over the pandemic, that easing up the regulations on telehealth use made a world of difference. And yet we do not see them being extended as much as we'd like to see. Like, let's make those permanent. Let's move forward. We've proven their value. So I think there are solutions out there for policymakers, and going off of what we have shown to work, and I'd like to see those pursued quickly.
Thank you. Bob, how would you answer that? How are you using telehealth, virtual care at Reedsburg? What's the potential of this, but also what are some of the limitations?
Well, I mean, first off, the main area that we use telehealth is in our behavioral health practice. We have patients that choose to, receive their services via telehealth versus coming into the clinic and seeing either one of the providers or the therapists and so on. So that's the main area that we see use of telehealth. We also have some telespecialty services, whether it's pulmonology or different ologists that we can bring into the organization remotely from that perspective. There are a number of rural hospitals that are using like a tele-EICU or for neonate services, those types of areas. We haven't dug into that. Years ago, we had a telemedicine service for hospitalists, but now we've just seen our numbers increase to the point that we have in-person hospitalist services. So there are a lot of opportunities for rural organizations to use telehealth services. I think, as creative as you can be as to how you can best use those services, it's a win-win for everybody. We did find that the patients do agree with telehealth services. It wasn't a distractor for them, and they were certainly okay with it.
How is the federal shutdown impacting virtual care?
Well, again, the biggest area for us was behavioral health services in the rural health clinic, and we were not affected by that. So we haven't seen as much of an impact from that. One of the dermatologists that works here did some telehealth services, so we had to change that. But overall, again, for Reedsburg, the vast majority of the services for telehealth are behavioral health, and that was not impacted in the rural health clinic.
Reba, how are you using virtual health, telehealth at North Lakes?
Yeah, we have a couple of ways that we're using it. And really to John's point, it doesn't always work exactly the way people think it. It's not necessarily a patient at home and a provider in a clinic. It's oftentimes our clinic to clinic telehealth use is much higher than our home to clinic telehealth use. So we have patients who come into our clinic in Iron River and access a provider who's in a different clinic, but they're in our clinic using our space. And so thinking about how to be creative with space, how to maybe change reimbursement models to support people being in the clinic to support and care for those patients, to do the labs, et cetera, and then interact with the provider who may be in a different clinic. I think is really important. But that's been a real gift to our patients, because we don't offer the same services. We have 19 clinics, but we don't offer the same services in all 19. And so that gives us an opportunity to give all patients in all locations access to all services, which has been really key for us. And also we have things, for example, like in Ashland, we have virtual optometry. We don't have an optometrist on site, but we are offering that service there. And we have opticians and optics. And so we have all the support except for the doctor. And that's going beautifully. So I think a lot of people still in rural areas, if we can put a clinic close enough to them, they want to come to the clinic. Especially as people age. We have winter storms, and it's the 80-year-olds who show up every single time. So our aging population really, they like to come into the clinic and see providers and see the support staff. And so trying to figure out how to keep that human touch in telehealth, I think, is really important in rural areas. That is a real, that connection is very important to our patients. And so not relying on the super high technology end of that, but also recognizing that accessing people from far away is not new technology. That's like phones, right? We've had that for a long time. But how do we maintain that connection, I think, is really important to continue to have that be a match for the values of a rural community.
What about AI, Reba? What about AI? Are you started to use that at North Lakes as you're shaking your head?
Yeah, a little
what do you
bit,
think the
but
potential is of that in terms of addressing some workforce challenges?
yeah, it's a great question. Not something that we have dug very deeply into yet. So I'm anxious to hear if other people are having more luck or experience with that than we are.
Bob, what about you? How are you using AI at Reedsburg?
Yeah, we're just starting to dip our toes into AI. We have one provider trialing an ambient AI listening technology in the clinic setting. So we're very excited to see how that progresses. We are an organization that uses Epic, but we're a child site. So we're a Community Connect site. So we don't have all of the control that we would like to have, but with implementing some of those new technologies. We're also using AI technology in the meeting space. So to have AI listen and do some of those notes for us. The accuracy and the detail of the notes are impressive. However, there's a little bit of fear about where are those notes being stored. Somewhere on some cloud, those notes are being stored. So we want to make sure that that everything is still safe and secure and private from that perspective as well. But to me, one of the biggest things that I'm looking forward to this year is going to be trying to implement more ambient AI technology services in all the clinic settings throughout the organization. I think it provides great opportunities for staff, provider satisfaction. It should allow them to go home when the workday is over and not continue to chart. So I'm really looking forward to this technology. I think it's got some great opportunities for us. Anything cyber related, we always are fearful about the unknown. So we have to learn more with any type of IT technology and what are the cyber risks and threats that come along with that. But I'm still extremely excited and looking forward to this technology.
Yeah, John.
Just something about that. I think what you've just seen are two providers who are working in their communities who are talking about kind of the realistic application. So much of AI is sort of media frenzy. It feels like a bubble. It's VC supported. There's a lot of hype about how it's going to revolutionize things. And I think the reality is people are using it in a cautious way because we have to in healthcare. You can't just like, hey, let's try something crazy right now. So there's that, but then I think also the other side to it is that you've got a large urban facility. They have more patient volume. They have more resources to experiment, to try something, versus if you have a smaller facility, their margins are much smaller. They don't have a lot of buffer to say, hey, let's invest in these expensive things with the hope that it'll work out. So I think what you're seeing more in smaller facilities is a bit of a wait and see. We'll see what catches fire in the urban facilities, and then we'll get our version of, we'll take a chance on our version of it. So I think those two responses you just had were really indicative of what you're seeing in rural.
Dr. Kine, what do you think? I mean, is this a lot of hype? I mean, what impact do you think AI, what could be the potential of AI on rural healthcare, especially as we try to address some of these workforce challenges and gaps?
Well, I think it's an excellent question, and all of my colleagues have offered really, really wonderful answers. When I think of future-facing technologies, I think not just AI, but also thinking about digital technologies and robotics. And I do think that we are likely on the edge of a sea change around handheld diagnostic devices as well as communication devices. Every day, I think we're a step closer to the Star Trek worlds of the future as we're thinking about what can be done in the home, what can be done with a single provider, looking at a patient or thinking about information that they get from afar. Part of that is AI, but part of that is also designing innovative new techniques that bring diagnostics to the patients where they are and bring treatments to the patients where they are. This requires us to be really partnering with our rural providers because too often I am seeing AI tools or digital tools or robotics tools that are being designed in academic centers or in industry groups that are primarily in inner city or suburban urban areas. Now, I do know that there are many, many industry partners, many researchers, many frontline rural individuals, delivery providers who are interested in coming together to develop something specifically for the rural space. And I do think that this is yet another reason to call for the types of investments that we were talking about on the Rural Health Transformation Program, because the more interconnected we can all become, and the more true partnerships we can stimulate, the more opportunity we can have that the rural hospitals, the rural health systems, the rural clinics themselves don't have to do these investments, but that the investment for the funding for this innovative approach is being done in step with industry, academia, and the federal government. Just as an example, we have a new researcher here that we recently recruited to our Department of Emergency Medicine who worked for NASA. And he is an engineer that designs new robotics and digital technologies to deliver care in the space setting, but is using rural medicine as the kind of the learning model for that. And obviously the very big difference between rural communities and sending an astronaut to the farthest realms of our universe. However, thinking about some of these very interesting approaches as we reimagine the future and ensuring that it's not all lifted on the shoulders of our rural hospitals and clinics, but that we can bring together some of these new bridges that ultimately can completely reinvent the way that we deliver care. Granted, that's a very big pie in the sky kind of vision, but I think that's where we can go as a state. I mean, Wisconsin really has a lot of groups that can come together, can think about these shared areas of goals, and to see more of this connectivity, both from a digital standpoint, but also from an organizational standpoint, I think is a real promise. So partly AI, but I think it's bigger than that.
Thank you. So we are quickly running out of time, and I kind of wanted to piggyback off of what Dr. Kine's statements to kind of conclude things. And hoping each panelist can ask this final concluding question. What do you think rural health in Wisconsin is going to look like in 5 to 10 years? What do you think will be some of the biggest changes? And Reba, let's start with you. What's the future of rural health in Wisconsin?
I think it's such an interesting question, and it feels so much right now like it could go all kinds of ways. But I do think, to Dr. Kine's point, that we have so many opportunities to think about how to do things differently. And one of the things that I'm really, really hopeful about is that we stop being as siloed as we are, that we recognize that we need to put the patient in the center of everything that we do. And so we really need to work across platforms on all levels. And the technology is getting more and more supportive of that. So how do we use that to ensure, especially in these smaller communities, that we really are working together, that we're not competing or cooperating or whatever the crazy new words are about that kind of thing, but we're truly collaborating because the patient is what's important. We are the rural patient, and we as rural healthcare providers understand what that's like. So, so how can we make sure that we're wrapping around patients? I hope that's what healthcare looks like in rural communities in Wisconsin.
Thank you. Dr. Dodson, what do you think will be some of the biggest changes in rural healthcare in the coming years?
I think that partnerships with academia, with business, with industry will do a lot of the things that both Reba and all the panelists have mentioned. I think wearables, point of care ultrasound, all kinds of technologies that now literally exist that we are training our students to use day in and day out, will revolutionize what we can do in places as long as we have the desire to do that. And so I think that the partnerships that we're experiencing will continue to grow. I hope to train students and residents in smaller communities and provide them the resources to make practice sustainable and joyous in those practices.
Thank you. Bob, what are the changes that are coming to rural healthcare in Wisconsin in the coming years?
Well, first off, I think the changes are unlimited. We can continue to have very strong, viable organizations that are attracting and retaining high quality staff and providers and providing an excellent patient care product on the backside. But to do that, we also have to work with our communities. We have to make sure that our communities are continuing to focus on the economic development. Do we have housing? Do we have daycare? Do we have schools? Do we have the churches? All of the things that are going to attract people into our community. So we have to continue to maintain those partnerships, but sky's the limit. I will never ever say Reedsburg Area Medical Center cannot do this because we're a critical access hospital.
Thank you. Dr. Kine, what do you think?
I think it's a time of great challenge, but times of great challenge can also bring times of great transformation. And I do think that that's what we are potentially on the cusp of. As long as we are brave enough to really embrace a change in the status quo. Certainly what's been done for the last 30 years is probably not what's going to work in the next 30. But that is true of all change. It's true of all development. And I think there's great, great promise. We certainly here at the University of Wisconsin and certainly with the Orion Initiative look forward to continuing these partnerships and learning from our rural frontline providers who can help us understand how best to design programs and technologies and new learnings to meet the needs of our rural communities. So I think it's a very exciting time. Obviously, there's a lot of stresses, but it's a very exciting time.
Thank you. John, we'll give you the final word. What's the future of rural healthcare in Wisconsin?
Well, for one thing, I really want to echo Bob's point. You cannot separate rural healthcare from rural economic development. When patients don't have enough money, they don't have enough employment, that really impacts the healthcare and it impacts the bottom line of the healthcare providers. And that being said, I think our economic system and our political system, where we have legislators running for office every 2 years, they're thinking about short-term answers. And I think a lot of these issues are intractable. I've been doing this for over 20 years. Outside of technology, we were talking about these same issues 20 years ago. So what we need are long-term solutions. That's a difficult thing to fund. Say, well, let's invest in something that's going to come back in 10 years. You see that in the medical schools when they're saying, let's get a first-year med student in there so that 7 years from now, we're going to have somebody in an office somewhere. But at the same time, we need, as a society, to come together, invest in economic development, and invest long-term to make sure we have the right healthcare for all our citizens.
Thank you, John. And thanks to all of our panelists. This has been a really great and informative discussion. We really appreciate you taking your time with us today. Thanks to our generous sponsors for making this possible. We'll be back in person for our next event on November 13th in Milwaukee, where we'll be looking at how changes to the mental healthcare system have impacted the region. Thank you all and hope to see you at our next event. Have a great day.